Great to be here again for this discussion. Look, really, really interesting choice of paper. Triple negative breast cancer, which is, I believe, around 15 to 20% of all breast cancers, is really the worst prognosis of different breast cancer types, and there's an urgent need in that field for treatment. So, whilst we've seen some success in not only other breast cancers, but actually other types of tumours as well with targeted therapies and immunotherapies, this is one area of breast cancer that I think has been particularly challenging. And great to see some advances made in this field, albeit in a sort of animal model, really, really good to see advances in that area with some potential implications for the clinic.
As you mentioned, I treat a little bit of breast cancer as a radiation oncologist, and definitely triple negative breast cancer is something that's a challenge. It affects younger women, and it's something on the clinical side we have difficulty with. I thought the thing I really found interesting about this study is that they used the mechanical ablation, which is a little bit different than a lot of the when we have used ablation clinically, we typically think of thermal ablation. It could be in this paper they used HIFU, which was an ultrasound-based thermal ablation, but in the clinical space we use radiofrequency and other invasive types of thermal ablation. But they took a little bit different approach where they used mechanical disruption, so you don't necessarily cause coagulative necrosis.
You're right. Ablation therapy's been around for a little while, and we see cell death with necrosis, but tumors often grow back, right? And so actually using the mechanical disruption, the shear stress resulting from that acoustic cavitation with the mechanical high intensity ultrasound was a really innovative step. And then obviously they got good results with that alone, but combining it with the PD-1 therapy as well, I thought was great.
Well, I found this just quite interesting in general. I mean, the thermal high-intensity focus ultrasound seemed quite... it's mentioned that it's non-invasive, or let's say minimally invasive, but anything that's going to be causing thermal stress and damage through necrosis is going to be a little bit more invasive than something that is essentially backing off a little bit. So the mechanical aspect of this does seem to be the novel point of this paper, where they're using a slightly less intense version of the high-intensity focus ultrasound to cause acoustic cavitation, which seems to, rather than just forcefully smash open the cells and destroy them through necrosis, it seems to be encouraging a more apoptotic reaction from the cells and a way to open up the cells to bypass the immune checkpoint and to make the body just systemically more aware of the tumor antigen. So I thought this is, rather than the kind of forceful destruction of the cells, focusing on the way to essentially just wake up the immune system to them, seems like a really novel and innovative approach.
Yeah.
The one thing I found interesting is typically when we think of apoptosis, it's not immunogenic because, normally that's how cells die. When we don't want it, it's the body's natural way to eliminate cells without causing an immune response. Clearly, they do show an immune response, so it's a little bit different than what we traditionally think of. And it seems like they may have a couple of different things going on, not just the apoptosis. They definitely do show that they have immune activation, but that was something that needs to be looked into a little bit further.
How tumors evade that kind of immune surveillance, right? I mean, that's, for our bodies have evolved to detect tumors and attack them. And, tumors like this in particular can evade that. They kind of outrun the immune response in a way. So that was one of the things that was really exciting here. It's not just about that thermal ablation, but, seeing that infiltration into the tumor of CD4 positive, CD8 positive T cells, getting that immune response. Even the gene expression work as well, showing, elevated expression of genes that are involved in those, antigen presentation and cytokine receptor interactions was really exciting. And for me, seeing the effect on tumor size as well on the kind of flank tumor on the non-treated side was, really indicative of a strong immune response that's then working.
So, one of the hallmarks of cancer, when they publish that paper, is that you have to have they have to evade the immune system. We definitely see more tumors. If we go back to the AIDS epidemic, there was tumors that we never see, like Kaposi's sarcoma, and things like that when we lose our CD4
Yeah.
cells. In our transplant patients who we immunosuppress so they don't reject their organs, we see increased cancers, oftentimes skin cancers, and some of these cancers that we know are classic of immunosuppression. And so, and there's a variety of ways in which cancers can evade the immune system. They can hide their HLA antigens so that the immune system just can't recognize them. They can express immune checkpoints to press an immune response, and they can make a poor metabolic environment. If you have increased lactic acid and poor metabolomics, you won't have the T cells won't be able to survive in that tumor microenvironment. There's a lot of work going on in that space. There's multiple. There could be immune suppressive cells releasing suppressive cytokines. So definitely, we have made large gains. Immunotherapy now is being used to treat many different types of cancer. And breast cancer, we're still working on it compared to others, but it's changed our treatment for melanoma, skin cancers, renal cancer. And so definitely we're making great strides.
Well, immune checkpoint inhibitors are quite interesting in themselves. They're almost like an ID that the cell has to show to the immune cells as they go past. It's like, yeah, I should be here, so don't destroy me. So things that really need to be done in order to target these cells is to expose the oncogenic antigens. This paper in itself seems to be focusing on this novel version of the HIFU. So the thermal high-intensity focused ultrasound, it seems that around this there are some papers that focus on the use of this treatment for prostate cancer, but less so in other cancers. And this is an animal model paper, so we should really be aware of this. So there is clinical data for the thermal version of the HIFU, but not so much the mechanical version of the HIFU to be able to open these cells and increase the number of dendritic cells and just generally stimulate the immune response. So this seems to be more of a proof of concept paper than something that is directly applicable to the clinic.
Even the tumor models they use, those of us who do preclinical animal research know that they are a little bit immunogenic. And they also added HER2 antigen, a human HER2 antigen, which will cause an immune response in a mouse. They're growing tumors, so and definitely doesn't invalidate their studies at all. But these tumors are not going to behave like human breast cancer tumors. And they are going to be more immunogenic. Right. Some of that distant tumor response that we are seeing is something indicative of this cell line and the immunogenicity in less immunogenic cell lines. The one other thing I was curious about, in the first figure, they compare no treatment, thermal HIFU, and mechanical HIFU treatment alone. And it didn't seem like the thermal HIFU really did much. To me, it was unexpected because if you heat a tumor properly to 60 degrees C and the whole tumor, there should be a primary tumor effect, even if there isn't a distant one. And I know in their methods they talked about not treating necessarily the whole tumor with that dose, but that was something that was curious for me, just because I think the point they were making is that this combination works well, but they have a pretty significant difference in just the treatment alone, even without the combination.
You know, one of the key novel aspects of the methodology is this mechanical shear stress through the acoustic cavitation, and the temperature was a lot lower. I think it was 42 degrees compared with 60 degrees with the thermal ablation. So you've got, you know, a necrotic response as opposed to this trying to stimulate this immune response and get some separation as well between the cells and the tumor.
I think one of the reasons they may have chose it, and I think it was appropriate maybe for one of their models, is it's an antigen, so they might be able to look at HER2 reactive T cells. Right. But I agree with you. We do have a lot of HER2 treatments, actually, and our outcomes for HER2 positive disease are much better on the clinical side, especially now that we have dual HER2 treatments. We're seeing really strong responses. We have really good clinical therapies to target HER2. I mean, obviously, there's still patients who escape, and we need to still work on it. But compared to triple negative, and the additional point is that, again, it may have been kind of interesting if they added mouse HER2, that would not cause, rather than human HER2, to a mouse cell line, and especially when you're doing immunotherapy type studies.
So the synergy between the two treatments here is fascinating, right? I think with anti-PD-1, we saw 26% kind of response compared with 52 when that was combined with the mechanical HIFU treatment. So there's great synergy there, and the combination of the two is really powerful. One of the alternatives I have seen in the literature is using this kind of immune checkpoint therapy in combination with chemotherapy.
So chemotherapy is used often. It depends on the chemo agent. I think the difference with chemotherapy is it's a systemic therapy. It will go to all sites. Probably something that maybe you better to consider for someone with metastatic disease. I think that's something very similar to this that I often do. I'm a practicing radiation oncologist, and my lab researches radiation immunotherapy. So we often use radiation. We cause immunogenic cell death to a local area and then combine it with checkpoint blockade. It's something that we're doing on the clinical side, and then has been in multiple clinical trials, as well as there's been multiple preclinical studies showing that there's also this kind of synergistic effect where you cause damage to cells with a local therapy, and that makes immune checkpoint blockade better.
I'd love to hear Anthony's opinion on this, but just one quick question on that then. Just while we're talking about that radiation therapy and that being localized, do you see a case for then having a kind of three-pronged attack with your radiation therapy, immune checkpoint, and maybe something like the mechanical HIFU as well?
Potentially. I think we need to study all of these, and we need data in humans.
Right.
I think one of the things that we don't have a ton of HIFU in the clinic that I'm aware of right now. It's a good salvage treatment when radiation, surgery, other local therapies are not available. That's kind of been where I've seen it in the clinical space. It's been used for prostate and some other diseases. But I think it has the potential for a much bigger role, but we need clinical data to show that it's used.
Absolutely.
But yeah, there's going to be patients who they can't have any of these other treatments. It might be hard to give radiation again. It could potentially work in a different way. And definitely that's something that we need to look at on the preclinical research side, and potentially, if we show good results, translate that into a clinical trial. But
so, yeah, one of my perspectives on this was that if you are looking at chemotherapeutic agents along with immune checkpoint blockades, that tends to act on a much more systemic level, whereas the radiation therapy, that's a lot more invasive and causes more damage to the DNA than something like this, even the thermal HIFU treatment. So it seems to be that one of the main focuses of this paper is to establish that the mechanical HIFU has efficacy in producing this immune response. It increases the number of dendritic cells in the area. It might have some more effect on the tumor-associated macrophages in those areas as well, and then impacting the tumor microenvironment. So rather than showing something that is functionally systemic from the start, it's a way to stimulate an immune response to get a sort of minimally invasive reaction from the whole system. So it would start locally to disrupt the tumor and then produce an immune response that could potentially take out other metastatic elements of this tumor on a systemic level later on. But one thing that was mentioned within the paper is that it's for it has limited efficacy with larger tumors. So if there's a smaller tumor that can be disrupted and then taken out on a systemic level by an immune response, that could be one of the potential ways to deal with any potential metastases in the future, rather than in a minimally invasive way, rather than doing some damage using the radiotherapy.
I think we need to be careful with abscopal responses. I think this has been a holy grail that radiation oncologists, local therapy people have been looking at for the last 10 years. And most of the clinical studies have been negative in humans, even with mouse data, multiple mouse data showing that it works in mouse models. So it's really fallen out of favor with clinicians, because it's something that it's a phenomenon that we see in mice and rarely in human beings. I'm not saying it never happens in human beings. We do see it, but it's not something we can reproduce in any predictable manner, at least to date. And looking at the tumor models that they used in this study, these are some of the same tumor models that we, with radiation or other therapies, that we show abscopal responses that don't necessarily correlate to what we see in patients. But this idea of we treat a local site and then get a distant response is something that that we see in mice, basically. And it really, we have not, despite multiple trials, been able to show in our patients.
You've got the tumor growth is decreasing. You've got this immune response. You've got the response in the flank tumor as well. So where the immune cells are actually operating and away from the treated site. But yeah, we need to then translate that into humans, and that will obviously be the next step to look at. But the nice thing about this particular treatment is, I guess, the non-invasive and lower toxicity aspects of it. Compared with, for example, in particular, chemotherapy, which, as you said before, is systemic. What do you think, Dr. Patel, would be some of the challenges to making that next step?
One of the things that we've been doing for local therapies is doing neoadjuvant studies. So at least for radiation, what we're doing is we're bringing up radiation and immunotherapy before surgery, and then we can see the response in our patients. And especially one of the trials that we have open at my center is for skin cancer, where we give it's not radiation immunotherapy, but it's immunotherapy up front, where we do surgery afterwards, and we can see this response. In breast cancer, potentially, let's say you have a patient with a triple negative breast cancer, potentially you can give this type of treatment prior to surgery, then assess when you take it out, did this generate a good immune response? It's not really, and when I talk about metastatic disease, we do have some data suggesting that it can prevent distant micrometastatic disease from developing, even if it won't hit large tumors like that we can see on imaging. So those are two different things, and that's still a clinically benefit. If you generate this immune response that can prevent these little micromets from developing everywhere. I think there's maybe some depth issue with ultrasound. It's sound waves. A surface tumor in a mouse may be a little bit different than a human patient who may have a more deep tumor. So you probably have to figure out a trial where we can focus the HIFU properly and maybe not go through bone. So maybe like a tumor inside a breast or something like that may make sense.
Presumably early diagnosis is still going to remain key and really critical to the success of any treatment, particularly in this type of cancer. But yeah, the other one is more of an engineering problem. So Anthony, combinatorial strategy that we talked about is really powerful, but there's lots now happening with the immune checkpoint inhibitors. What do you think some of the trends are in that area?
The concept of using cancer vaccines, where you would take out immune cells from a patient, stimulate them to essentially produce an immune response against a particular presenting antigen on a cancer, and then inject them to elicit an immune response that way. So potentially using this HIFU or HIFU, the mechanical version of this, which increases the immune response anyway, it could actually be a way to enhance the efficacy of such kind of cancer vaccine treatment in a more minimally invasive way. I'm not really sure how cancer vaccines are paired with other treatment like surgical resection of tumors and radiotherapy, but this could be one potential avenue for the way to enhance other immunotherapies like cancer vaccine.
Yeah, Dr. Patel, thoughts on that as well?
So to your first question, the immune checkpoint, we've been focused on the clinical side on PD-1, PD-L1, but really the data on checkpoints has expanded a lot more. Now we're using a lot of LAG-3 inhibitors, TIM-3, TIGIT, VISTA. Really the whole field of checkpoints has really expanded beyond the ones that we're using in the clinic right now. And we're doing combination with cytokines and other things as well. Those are in trials that that we have patients on. To Dr. Swain's point, one of the things as you were talking, that I found to be one of the problems with these cellular therapies is you have a fibrotic core, or you have an inhospitable tumor microenvironment where immune cells can't infiltrate. And one of the things that I don't know if this paper specifically focused on it, but they did have some data showing increased T-cell infiltration. Could be that if you disrupt this TME so that this fibrosis or this inhospitable environment is broken up, loosened up potentially, put in lay terms, that maybe immune cells can infiltrate more. They definitely did show they have more immune cell infiltrate. I think it wasn't necessarily the whole focus of this paper, but that might be something to look at compared to other modalities. Can they break up these areas of tumor so that immune cells can get in and attack?
Yeah, completely agree. And it was actually, it was quite a strong immune response that we saw with infiltration of CD4 positive, CD8 positive T cells, but also, cytokines like interferon gamma were all up within that tumor microenvironment. So yeah, whether that's down to that shear stress that we talked about before, just sort of giving a bit of separation, pulling apart some of the tissue, breaking it up a bit to get the immune cells in there, or not, will be really interesting to see, but certainly look very promising in combination, right? How is that field evolving? What are some of the emerging treatment modalities that we're seeing that are maybe non-invasive or a lot less invasive than what we've seen in the past?
So unfortunately, I don't think we've come up with a cancer treatment that has zero side effects. I tell that to all my patients, but we want to do, everything has to have a benefit, and we want to minimize the cost or risk to our patients. And that's a conversation, anytime you're in a clinical situation, talking about a treatment with a patient, that's the conversation I have with them. So, and we'll take more risks when we can cure patients to cancer, and maybe a little bit less risk when we're not going to be able to offer much benefit and we just want to palliate some symptoms. I don't know if we have a true non-invasive, non-side effect therapy. I remain doubtful that even mechanical shearing has zero side effects. It's sometimes hard to detect that in mice just because they can't speak and complain. Even if I radiate a mouse tumor, you're not going to see most side effects because the mouse can't speak to them if I'm just radiating that mouse tumor. But it does seem like this may have less potential for toxicity. I still think there's going to be some, but it's going to be potentially less than a thermal ablation. I would be curious to see how it would compare to radiation because radiation doesn't, it does cause DNA damage, but I'm imagining that this mechanical stimulation they're causing does kill cells. We see that from the treatment alone without checkpoint. So I'm not going to say it kills zero cells. And there's probably some likelihood it'll kill some normal tissue cells too through shearing. We just don't know the level and how fine they can control it. At least I couldn't gather it from this study. And systemic therapies are sometimes much harder to tolerate, especially when we're talking about cytotoxic chemo.
No, and so it'll be really exciting to see how that emerges. So when most people think of ultrasound, they're probably thinking of it in a diagnostic sense or going along, to see a fetus, for example. Actually, more and more it is being used as a therapy as well, and it'll be really interesting to see how that evolves in the kind of oncology space. So, yeah, Anthony, did you have any thoughts on the non-invasive modalities or less invasive modalities?
Yeah, I was just about to say that probably non-invasive is a little bit optimistic because anytime you're going to be doing any of these therapies, it's going to be causing some kind of damage. I cannot think of any sort of non-invasive therapy at all. Even if you have a headache and you take a paracetamol, there's some kind of trade-off for that in the sense that the paracetamol itself could cause some damage to your liver in certain circumstances. Right. So there's always going to be some level of invasion whenever you're doing any of these therapies. I do think one of the main focuses of this paper was to present this mechanical high-intensity focus ultrasound as a less invasive alternative to the thermal high-intensity focused ultrasound. But it's a little bit optimistic, and with it still just being a mouse model, it is one of the big problems. Unless you get the data in the clinic, it's very difficult to pronounce any sort of efficacy within humans, because as Dr. Patel said, mice can't complain what you do to them. There's also the fact that the size of the mouse body as well is completely different to the kind of scale that you're going to be dealing with a human. Anything's going to be more invasive if you're looking at like the size of a mouse leg, for example, which is one of the areas which are focused on within this paper. That is a completely different scale to like either a tumor in a human femur, for example.
You're right. That brings us back to what Dr. Patel was saying before about deep tumors as well, and the ability of HIFU to be able to reach those.
They use breast cancer models where we can do an orthotopic injection into the breast mammary gland. And I did find it odd that they didn't do that for theirs. They did an intradermal injection in the leg. And it's a little bit different than most people because the mammary glands are pretty near the surface and it's not a hard procedure to do. And I would expect HIFU would still be able to get it, but intradermal is like right on the surface. It's in the most superficial layer of the skin, so that does make me wonder, can we even go a little bit deep? I think it can, but it would have been nice to see that.
Maybe that's a next step. Maybe that's something they're working on at the moment to try in different locations and see how deep the HIFU can penetrate. But that's actually a really good point. Yeah. So one of the challenges for researchers, and here we had a group that's sort of split between Japan and the US, is communication of results. And there's a lot of results here, a lot of data, and it's a complex field, I would say. So, Anthony, what were your thoughts around the science communication here, the writing style, how the authors were able to communicate these results?
I thought it was, pretty good and pretty logical. I thought some of the results, some of the sections of the results seemed to delve a little bit more into the discussion section. Probably I would have written itself as like, but it does seem quite logical in the sense of that we tested this, and based on these results, there's a little bit of interpretation of the results, but that's used to provide logic to move on to the next step. So
storytelling.
It's very good in terms of the storytelling of that. Yeah. But one of the things that I found within this paper itself was that in general, I thought it was quite interesting. Some of the like the title, I thought the title of this paper is "Combination of Ultrasound-Based Mechanical Disruption of Tumor with Immune Checkpoint Blockade Modifies Tumor Microenvironment and Augments Systemic Anti-Tumor Immunity." I'm wondering if there was any choice, specific choice for using the single tumor rather than tumors in general.
You're right, and you're right to point out the extensive discussion of limitations. And of course, there are many limitations and many questions that come out of this, which I think the three of us have already covered a lot of. But yeah, there is a nice story that they generate here. And you're right, there's some interpretation included in results, but actually part of that is just to present a logic for the next part of the story, which I thought they do quite nicely, actually. Yeah. Now, Dr. Patel, you may be a little biased here, being an editor on the journal, but what were your thoughts around the writing, the storytelling?
I thought the writing is great.
We both thought it was good.
I thought the writing was great. Storytelling was good.
Yeah.
On the science and things like that, I do think they were probably missing a few controls that I would have liked to see if I was reviewing it. They do a lot of comparisons between untreated and the mechanical HIFU, but at least in the figures, it looked like there was limited direct comparisons, at least for many of the analysis. I'm not saying they do have some, but between the thermal versus mechanical, which is, I think, the main point of the paper, which I was a reviewer, I would have asked for them to show that data. Obviously, it would be a little bit harder to show significance because I do think the thermal's doing a little bit, even if it's not doing it's mechanical.
Yeah.
I really agree with this point, actually. It did seem like there were some sections of the paper where I was just looking at it going, where's the thermal?
I think they moved on quite quickly to show some initial results comparing the thermal with the mechanical HIFU, but then they move on to really the next set of results are comparing mechanical HIFU alone with the combinatorial treatment. So I think that's the crux, the thrust of what they're showing in the results is how the combination of these is actually really good. But you're right, they could have actually shown a bit more in terms of what's happening with thermal only for some of those later results.
Yeah, especially if they want to validate that it's better than thermal.
So, and as an editor, you say you didn't review this, but what sort of qualities do you look for then in a paper when considering whether to accept or whether it's of interest?
So I don't know if I know the answer to this because I get as many papers rejected as accepted. It's a difficult thing for all of us, whether you're an editor or not.
Right.
But I think that the rigor of the science is a big thing. I definitely look for having multiple tumor models, especially if you want to publish in a higher impact journal. And they have more than one different tumor model that they used here. Sometimes I look for multiple replicates. I think in this paper, I wasn't sure if they had more than one replicate, but especially when you're looking at immune studies, those of us who've done mouse studies, it's not, you may get a result once, but you may not get it the second time. So reproducibility is not just having statistical power, but having reproducibility really helps. I like to see that. And it's what you can do is maybe instead of powering your study and doing everything at once, you can do 2 replicates. So you show reproducibility and still have that power for your survival analysis across your replicate.
That's a good point, actually.
I think they have really nice single cell analysis and complex techniques, which is obviously helpful. We like to see lots of data and the analysis they did.
Yeah.
As I mentioned earlier, don't skip controls because some reviewer, if you get a reviewer like me, is going to ask for them. And then, because, when we read a paper, we have that question, like, what would these two things look like? And then I guess the last thing is, at least when I've tried to publish in high impact journals, I think the reviewers, for the most part, are trying to help you. They're interested in seeing the best product come out. I tend to follow their advice, and if they ask me to do more studies, I do more studies. There's some people who push back and be like, no, I did enough. Obviously you can't do some things if there's a patient that you can't run a new clinical trial, but if it's doing a few extra mouse studies, it's usually worth doing, because your data will be more rigorous and more robust. And I know when I had my big paper for my postdoc, I spent a year doing these studies, and the final product turned out much better. It made my data much more presentable.
100% agree, and that's I think for some of our listeners, they might be thinking, well, it's going to take extra time, and it's a real hassle having to do this. But that's a key point, that the reviewers are there to help you make your paper, make your study better, stronger, and really stand up to scrutiny once it's published. So yeah, absolutely. Brilliant point. And Dr. Swain, you're very experienced now with supporting authors and working with authors to get their work published in high impact journals. So, any final thoughts around, in the context of this paper, what qualities you think are particularly important?
Well, most of the studies that I work on tend to be clinical trials, whereas this is a non-clinical trial. So you need to make sure that you have all of the a well fleshed out methodology section, which I think they did really well in this paper. It's very detailed in terms of all the methodology they use: the flow cytometry, the ELISA, the single cell RNA analysis. Yeah. Very thorough. The paper utilized a lot of supplementary materials as well. So it's clear that there is a huge amount of data within this paper, but the authors also utilized the facility of the journal to add supplementary data, which was excellent. They really did cover their bases, even if it wasn't within the main paper. Their online supplementary material is incredibly extensive. One thing that I potentially would have advised the authors to, well, it got published without this minor criticism that I have. But the title itself, it doesn't mention anything to do with breast cancer, and I think that it potentially would have added more to the specificity of the paper to mention that this is a breast cancer model. It clearly didn't impact the paper getting published in any way, shape, or form. And beyond that, there's not really much that could be added to it, other than some potential other minor visual things that I would have potentially added, like matching the way that the graphs present the non-treatment, the thermal HIFU and the mechanical HIFU. I would have used the same symbol in each particular graph, but beyond that, it's very nitpicky what I have to say about it.
Lots of work, lots of figures, including lots of supplementary figures. You're right about the imagery. For me, I would have really liked to see a schematic, or almost like a graphical abstract, but some kind of schematic that pulls everything together to tell the story, because there's a lot of results. They're very spread out, and it's complex. And being able to boil that down into a single figure that just captures what this paper is about, I think would have been really nice. And, a lot of journals now publish graphical abstracts, and I don't know if this is one of them, but they're becoming more popular and more used as a vehicle for communication. Apart from that, I thought it was very thorough and a really nice piece of work. Any final thoughts, Dr. Patel?
No, I think this is definitely an interesting concept. I'd love to see more work come out of this. I do think this has some potential application for breast cancer, but it could apply to other cancers as well. And it would be, especially that mechanical disruption of the tumor microenvironment. A lot of the solid, dense tumors that we have, the classic is pancreatic cancer, but there's others as well. Can we limit, or can we break that up to allow immune cell infiltrates? I think that would be a great potential follow-up study to look at this type of technique, because that is a really big problem. And you can, instead of doing checkpoint blockade, that's one of the problems that we see for these cellular therapies like CAR T cells that don't work as well in solid tumors. And so you can directly investigate, if I break up this tumor, can I let immune cells in? But no, I think it was a study with a lot of interesting data, future directions that could the investment.
Yeah, I really look forward to seeing where this this type of treatment goes next. And you're right, implications not only for breast cancer, but for a ton of different cancer types. So, Dr. Swain, any final thoughts there?
No, excellent paper. I'm looking forward to seeing more of these things in the future, preferably in a clinical model rather than a transgenic mouse model.
Yeah.